Time. Before I open it up for questions, a couple very quick comments. One is that I'm glad to see, both perspectives, public health and population health, are sort of merging. In 2014, when we had this session, which half of the people showed up, like it was around like 80 people or 70 people. We had a debate actually to find out where is that middle point between public health versus population health. And then after that, we actually published a paper on that in AMIA after getting, revision requests for 5 times on what population health informatics is, because we don't want to, create a new domain, but then there was an understandable sort of a mutual understanding that yes, there is something there. And then I'm very glad to see that today we have both sides actually, they're eager at least to start on something, and that's social determinants of health. And that might be partly because if it was only the vision that they had, public health departments and population health sort of management centers, if it was only the patient's overall health, something like that vision that matched and aligned like a couple years ago. These days, it's not only the data that matches that they need to share, it's also their dollars are now tied into it. And I give you an example here in Maryland, all of our hospitals, because of the way we're on global budget, so all of our non-federal 45 hospitals, they get that much money at the start of the year, and that's it. No matter how many visits you have for the patients here in Maryland, that's it. So you want to do what to keep most of that at the end of the year? You want to do prevention. So as a health system, suddenly you're intrigued talking about falls. We have a project where we are predicting falls for health systems, and then they have risk scores for patients. So if the risk score of an elderly having a fall is high, they're willing actually to send somebody to their houses, if it's a house-related issue, to fix their house for a fee for free. Because if they spend like $3,000 to fix that house, it would prevent $1 million loss to them for a hip fracture and everything else that would eat their global budget. So that's sort of pushing health departments to become, pushing health systems to become mini health departments. So this is where the merger is happening. The dollars are not sort of aligned. The public health departments also see that their revenue and their sort of there is definitely stars are becoming aligned, but hopefully we can do something here. So now I want to open it up for questions. There is one here.
My question for Ms. Scholl. You raised multiple points, which forgive me if I have a couple of sub questions in there. For people in the room, I don't know if you're aware, NCQA, other than the federal government, has immense power into the direction of healthcare in the United States, because its artifacts link care delivery and care reimbursement. So when I look at the HEDIS 2018 measure, I see, as you pointed out in your research, proxies, not actual social determinants of health measurements that hold people speak to the cloud. Is there any discussion about actually surfacing concrete social determinants of health metrics? And if so, is NCQA reaching out to the conveners mentioned in the previous panel that are trying to define the data model, the numerators and denominators that HEDIS will need to have? And then secondly, you see the PCMH on the Patient Centered Medical Home 2017. It's great that finally we have dental care for children, but we have one section on social determinants of health. And the magnitude of the plethora of factors in social determinants, I think fails. I think with the guidelines for PCMH 2017, I am just befuddled.
Okay, I guess it was loud enough so everybody heard that. I'm not repeating, and I guess it was close enough. So, Sarah?
Okay. So in terms of how do we think about social determinants, and are we interested in incorporating that in our quality measurement system? The answer is yes. And the question is, what's the best approach for doing that? So in the patient-centered medical home, that's an example where we're actually saying, here's some criteria. for what a practice can do, and we're moving the world incrementally to build on that. So like I said, we upped the ante in 2017 from our 2014. But this is in response to everything we do at NCQA is voluntary. It depends on the payers being willing to say, we want you to do that. And we're seeing more interest from the payers like CMS saying we're interested in this. We're seeing that health plans are interested. There's a question about the evidence base for what is the most important and what should we focus on. So the work that people like Siren are doing is going to be useful to that. But I think where we see the opportunity is really in the kind of discussion we're having around how to present the quality data and how to think about identifying the populations at risk and making sure that our payment systems use the quality metrics, and the payment encourages people to focus on improving care for the people at risk. So as what we've seen is that if you are responsible for hospital readmissions, then you have a payment arrangement that allows you to do other things beyond just provide clinical care and clinical visits. If you can help with housing or other things, we are seeing that health plans are doing that. So, and especially in special needs plans, we see that people are offering some more social determinants, addressing social determinants, because that's what will help them to improve or maintain their performance scores on the clinical measures that we have. We're also focusing on trying to move to outcome measures that will have more focus on trying to address these needs. If you're trying to improve outcomes like A1C control of blood sugar, or depression outcomes, then there's a lot of stuff you need to have in place that won't be medical. And so I think our focus is more on trying to move towards that outcome measurement and to provide systems that will encourage organizations to work to address social determinants by improving their scores for at-risk populations.
Okay, and just one comment on that. Here in Maryland, the global budget will be tied, 5% of it, fairly soon to population health measures. That means the population that lives around your health system, no matter whether they showed up in your health system or not. So that's a different way of adjusting a global budget. Yes, there's a question.
Just a follow-up, regarding you say pretty much every 3 years, 8, 11, 14, 17, quote unquote, up the end, standards are higher. Is there additional reimbursement that goes along with upping standards? Because in my experience, remember among benefits that we add on has gone down, whereas what you're asking us to do up. There seems to be a disconnect. Who's going to do all of this very good work? And the next question, I practice and work in the South Bronx, of course, because country, are you saying that you're not risk adjusting? Are you therefore penalizing the people who are working in these areas where patients are already struggling with lack of resources, and then you're not risk adjusting the scores? And clearly there's four measures that we showed. You see a correlation between socioeconomic status, all these other social determinants following that.
So the question was, one was, when we increase the limits that we are looking at in terms of measures, are we actually increasing the reimbursements levels as well or not? So hopefully it won't be like the sort of the meaningful use measures where they stopped because they couldn't go in the other direction. And another one was, why not risk adjusting, because that might be unfair to providers in low SES communities.
So the first question on the reimbursement. So NCQA is an independent evaluator. So we don't set payment policies. The payment policies are set by the health plans or the state Medicaid programs or Medicare. And so what we can do is provide the metrics that they can point towards. Now we're seeing that some states are pointing to specific standards and saying, we want you to do this. I know they're doing it for integrating behavioral health into primary care. I actually don't know whether we have states that are actually saying, we want you to do more on social risk and therefore we'll pay you more. But that's a good question. I'll take that. And, you know, we work with states and with providers, with payers and try to encourage them to use it. But I can bring that back and say this is something that we should be advocating to payers who use our tools. In terms of the risk adjustment, so we as an organization do not think we should risk adjust for social risk. Okay, we should not adjust. We adjust for clinical needs. We don't adjust, you know why? Because we think that that's going to hide the problems that our country faces in serving this population. That's why we think the measures are risk adjusted for the clinical factors. The way that we account for social risk is in how we present the data. And so it's stratified reporting, so we can say, you have a more difficult population. We want to show that what you're doing for that difficult population. We don't want it to be lost in the risk adjustment process, but we want the payment to be adjusted to address the fact that your population is more difficult. CMS is doing this for Medicare Advantage plans through its categorical adjustment index that changes the way that Medicare Advantage plans are paid based on the how challenging the population is. We want to, the stratification is a way to make this front and center, that this is a challenge. We're struggling with what data are available to actually do that kind of stratification, the methods for doing it. It's really tricky, but that is our feeling that the way to make this move is not to try to adjust it in the measure, but to adjust it in the payment policy and to make those differences, the disparities in care obvious, so that can become a focus of our attention. And that could be part of how organizations really try to win in a payment system. They win by trying to make things better for that challenging population.
Okay, we have probably 1 minute left or nothing left. So, our speakers, thanks again. Great. So we have now Susan.